Dear colleagues, respectful colleagues, this talk or this presentation will discuss high blood pressure in stroke patients. I'm Dr. Firas, consultant neurologist working in King Hamad University Hospital, Kingdom of Bahrain. Actually, to put a headline for this presentation, we can use the famous statement of Donald Rumsfeld, the known knowns, because we have facts that we know about hypertension relation and stroke, and we have other things that we don't know them, whether we know that we don't know, and other facts that we are unknown and unaware about them. In this presentation, actually, I will discuss only the high blood pressure in ischemic stroke patients, because already there will be a presentation discussing the treatment of intracranial hemorrhage. And even in ischemic stroke, I will concentrate on the acute setting of presentation of ischemic stroke, because there will be a presentation, another presentation for discussing the secondary prevention of stroke. The non-knowns about hypertension, that one third of adults, they are hypertensive. And 1 in 3 adults with hypertension, they do not know they are hypertensive. And 1/3 of hypertensive receiving antihypertensive medication, they failed to reach the level of less than 140/90. We will continue on what we know about stroke and hypertension. 75% of patients have high blood pressure on presentation, and 50% of them, they have prior history of hypertension. In the Asian Pacific study published in Journal of Hypertension 2003, the relation between blood pressure and risk of stroke was continuous, consistent, and independent of other risk factors. The study showed that a 10 millimercury decrease in systolic blood pressure was associated with a 41% lower risk of stroke in Asian population and a 30% lowering the stroke risk in Australian population. Continue with what we know about stroke and blood pressure, that the association between hypertension and different ischemic types of ischemic stroke is studied in many papers and in many researchers. Previous studies stated that lacunar infarction, especially multiple one, associated strongly with hypertension. There are other studies and systemic review studies stating that or contradicting these findings, and they found that there is no specific relation between lacunar infarction and hypertension, and the association of hypertension is with all types of stroke. Lastly, a systemic review published in Stroke Journal 2005, they found that there is a marginal association between lacunar infarction and hypertension greater than the non-lacunar infarctions. What about hypertension and risk of recurrence of stroke? Many studies found that there is a significant association between hypertension and stroke recurrence. In a study published 2003 in Stroke Journal, 24% reduction in recurrence of stroke occur when we use antihypertensive medications, whatever the type of the agents used. In a Prindopril study, we call it a progress trial, published in Lancet 2001, the antihypertensive treatment resulted in 43% reduction in stroke recurrence in hypertensive and non-hypertensive patients with history of stroke or TIA. What are the mechanisms whereby the hypertension can cause stroke? What we know exactly that hypertension has a deleterious effect on the cerebral circulation. It will it can affect the blood vessel structure wall, lead to hypertrophy, remodeling, and this can promote atherosclerosis in large vessel and can lead to lipohyalinosis in small penetrating arterioles. Hypertension also impair endothelium-dependent relaxation and alter the cerebrovascular autoregulation and the neurovascular coupling. These changes can lead to that hypertension facilitate occlusion of the vessels or a degenerative changes in the wall of the vessels that make them rupture. And in this way, we think that this way the hypertension can lead to both ischemic and hemorrhagic strokes. Now, I show you just some of what we know about the relation between hypertension and ischemic stroke. Now we will come to the area where some facts we will mention that we know, but other facts we know that we don't know. And this is actually in the setting of acute ischemic stroke treatment. The debate surrounding whether high blood pressure should be treated or not treated in acute ischemic stroke, it started over 30 years ago. In JAMA Neurology, in 1985, there were two papers, one stating treat and the other stating not to treat. And despite multiple clinical trials over these 30 years, there is no clear answer to which level we should lower blood pressure. And that's why the approach now is what we can call it act of balance. Because lowering blood pressure is beneficial in one hand, reduce reinfarction, reduce cerebral edema, reduce hemorrhagic transformation, but in the other hand, it can reduce cerebral blood flow, which can lead to increase the size of stroke. While raising blood pressure, it can increase cerebral blood flow, then increase collaterals, but it can, on the other hand, increase risk of hemorrhagic transformation. So how we can deal with those patients? We know that high blood pressure is, as we mentioned previously, it's occurs in 75% of patients on presentation. And we know that high blood pressure above 185/110 is one of the exclusion criteria for thrombolysis. And we know that lowering blood pressure is associated with good outcome in cases of intracranial hemorrhage. So the question here, can we lower blood pressure while the patient shifted to the hospital and he's in ambulance? The data available came from the RIGHT study, RIGHT 1 and RIGHT 2. The RIGHT 1 and RIGHT 2, which is rapid intervention with glyceride trinitrate in hypertensive stroke. The first study randomized 41 patients with suspected stroke with a blood pressure, systolic blood pressure more than 140 within 4 hours of symptom onset. There were no difference in 90 days mortality. But there is significant improvement in modified Rankin score with a shift of 1 point. The RIGHT 2 randomized more patients, around more than 1,000 patients, and the results show that there is no difference in the modified Rankin score and no difference in mortality. The study showed that 145 patients was randomized, and then we discovered that they are ICH. The glyceride trinitrate was associated with worse shift in modified Rankin score. A meta-analysis for these two studies involved these studies done, and it showed the same, that there is no difference in the treatment arm and the non-treat and the control non-treatment arm. Another two studies, which is FAST-MAG, which is the field of administration of stroke therapy magnesium. This study actually, it's tried to investigate the neuroprotective feature of magnesium. But at the same time, magnesium is a vasoactive agent. The result of this study showed that there is no difference between the two groups in modified Rankin score and mortality. The PIL-FAST study using lisinopril sublingually, small group randomized 14 patients only. And the result also that blood pressure was lower in lisinopril, which is sure because lisinopril is antihypertensive medication, but there was no difference in 1 week mortality between the two groups. Until the results of the future studies, which is the multicenter randomized trial of acute stroke treatment in ambulance with nitroglycerin patch, and the intensive ambulance delivered blood pressure reduction in hyperacute stroke trial, the INTRACT-4. Until the results of these two studies, we should restrict to the guidelines. The ESO guidelines, last ESO guidelines state the following. In patients with suspected stroke, they suggest against routine blood pressure lowering in the pre-hospital setting. and the expert statement due to the pre-hospital harm in patients with intracerebral hemorrhage. Pre-hospital treatment with the glyceryl trinitrate should be avoided. Now, our patient arrived to the hospital, and we check the criteria, and the patient is candidate for thrombolysis. And we know that if the blood pressure should be less than 185/110, and we should keep the blood pressure less than 180/105 during and after thrombolysis in the first 24 hours. But surprisingly, this threshold is not proven by a randomized control trial. And it was based on the protocol of the randomized control trial, that's to say the NIMS trial. Many investigators try to answer this question, whether this threshold is a real threshold, is the threshold that we should follow. In a single center observational study, it's reported that the break in the threshold, which is 185/110, occur in 12% in acute stroke treatment setting in one center in daily practice. And this break, they mean treatment of patients with thrombolysis, with the blood pressure higher this threshold, it was associated with higher likelihood of symptomatic ICH. In analysis of SIDS registry published in European Journal of Neurology 2018, they found out of the 11 off-label criteria, the only elevated pre-treatment blood pressure was associated with high odd of symptomatic ICH. Lastly, analysis of a clot past ER trial found that the break of the threshold occur at least in 34% of the trial, and it was associated with poor outcome, whether it's clinical or radiological. Lastly, the Enchanted trial tried to the other arm, that we should lower the blood pressure aggressively, the intensive blood pressure lowering. And the Lancet in Neurology 2021, the hypertension arm of the Enchanted trial published, and the investigator failed to improve the functional outcome, but lowered bleeding risk after intravenous thrombolysis compared with the guideline recommended treatment threshold. So, and even in this study, the exact blood pressure at which the risk of hemorrhage after thrombolysis increase was unknown, until the publication of the new studies included Enchanted 2 trial. We should follow the recommended guidelines. The last one, ESO guideline, recommend that we should continue following the previous recommendation, which is to keep blood pressure below 185/110 before bolus, and below 180/105 after bolus, and for the first 24 hours. And they recommend against lowering systolic blood pressure to a target 130/140 compared to 180 during the first 72 hours following the onset of symptoms. The other arm, which is now standard of care in acute systemics in acute stroke, is the thrombectomy, the endovascular treatment. What is the threshold for blood pressure treatment, blood pressure for which we should include patient in thrombectomy? We should keep the following facts, that most of the large vessel occlusion patients enrolled in the randomized control trial, they are enrolled within the 6 hours of symptoms, and most of them receive intravenous thrombolysis. So already we know that their blood pressure was less than 180/105. We know from many studies that the extremely high systolic or diastolic blood pressure before mechanical thrombectomy for large vessel LVO patients was associated with poor outcome or with worse outcome, whether it's a clinical or radiological. On the other hand, hypotension was associated with infarct expansion and worse functional outcome at 3 months. Lastly, the blood pressure targeted trial published in Lancet 2021, they stated that, conclude that for patients with successful recanalization after mechanical thrombectomy, there is no compelling reason to employ very aggressive blood pressure lowering treatments. Until the new studies and the new research found other thresholds, we should keep blood pressure of patients treated thrombectomy below 180/105 in the first 24 hours, And in patients with acute ischemic stroke due to LVO, the ESO guidelines suggest against actively reducing systolic blood pressure less than 130 in the first 24 hours. And in patients with acute ischemic stroke, we should avoid the drop in systolic blood pressure, and also the guidelines advocate against induced hypertension in case of thrombectomy. What about the choice of antihypertensive agents? Do we have any studies comparing the available intravenous antihypertensive medications? Actually, we have two studies, and as we see, the same investigators. The first is retrospective and non-randomized study comparing nicardipine to labetalol, and the second is a prospective investigating 54 patients, also comparing nicardipine to labetalol. The retrospective study found that nicardipine arm were more likely to achieve their blood goal at 1 hour than labetalol, and nicardipine associated with fewer dosage adjustment or need for rescue treatment. The prospective study found the same, and they found that none of the nicardipine group required rescue medication, while around 70%, more than 70% of the labetalol arm required the rescue medications. Now we have the treated patients. What about the non-treated patients? Those patients, we are excluding them, and we know that minority of patients will be treated by thrombolysis. Maximum reached to 20% of stroke patients treated with thrombolysis, and less than that with thrombectomy. What about those patients? The majority of patients that we don't treat them, how we deal with them? Many studies, including the PROFESS study, Scandinavian study, CHIPS in China, and Continue or Stop study, and Enchanted study, the nitric oxide study, all of them found that the initiation or reinitiation of antihypertensive therapy within the first 48 hours to 72 hours after ischemic stroke is safe, although this strategy is not associated with improved in the mortality or functional outcome. The recommendations of the ESO guideline and even the American guidelines that in those patients not treated and they are not candidate for the acute intervention and they are hospitalized, the pressure in those patients in the acute setting, pressure less than 220 over 110 should not be treated. And they suggest that the routine use of blood pressure lowering agent at least in the first 24 hours following symptoms onset, unless there is necessary for a specific comorbid condition. So they suggest not to intervene until there is what we call it end organ damage. And the expert opinion that if there is indication to lower blood pressure or the pressure is above 220 over 110, careful blood pressure reduction, that is say 15% of blood pressure reduction in the first 24 hours is reasonable. Now, the patient, the first 24 hours finished, and we want to continue or stop, because this question usually raised. Shall we continue the same medication, the antihypertensive, or stop? The analysis of the continue or stop data and the nitric oxide trial show that there were no significant association between continuous versus stopping previous blood pressure lowering therapy and the functional outcome at 3 to 6 months. Also, there was no difference in the mortality. Analysis of CATS study published in JAMA 2019, there were no association or difference between death and major disability, whether we initiate or stop. The Cochrane's data analysis published in 2014 show it may be worse, and there will be disability and the quality of life in the arm that with continued antihypertensive medication is higher than the stop antihypertensive medication. And actually, this can be explained maybe because, as we know, that many patients with acute stroke, they have dysphagia, and most of the antihypertensive medication used are oral medications. So until new studies appear, it is still unknown. It's uncertain over the initiation or stopping. It's uncertain until now, according to last ESO guideline. The expert opinion suggests that stopping the oral antihypertensive medication in the first 24 hours until assessment of dysphagia is there or the restoration of the NG tube there in place. So in summary, this algorithm is very nice, and it's found in an open access paper in Neurocritical Care, published in Journal of Neurocritical Care 2020. We classify patients into 3 categories. If the patient is candidate for intravenous TPA, the guideline is not changed. The blood pressure should be less than 185/110, and it should be kept less than 180/105 for the first 24 hours. In case of endovascular therapy, thrombectomy, we should also continue with the guideline, as in thrombolysis, less than 185/105. If the reperfusion failed, they suggest in this paper to keep the systolic blood pressure more than 150, according to ESCAPE trial protocol. And if there is successful reperfusion, systolic blood pressure should be kept less than 140, according to DONE trial. And if there is a hemorrhagic transformation, systolic blood pressure should be less than 140, also according to DONE trial. While the third category, those patients not treated, so if the blood pressure above 220/120, we should reduce it by 15% in the first 24 hours. And if the pressure is less than 220/120, the initiation of hypertension, of the antihypertensive medication, is safe, but not effective to prevent death or dependency. But in case we have end organ damage, we should also follow the 15% reduction. The last thing, where to reintroduce or reinitiate antihypertensive medication, we should start them at least after the 72 hours if the patient is neurologically stable and the blood pressure within less than the threshold we mentioned previously, and it should be started before discharge. Finally, what we know is a drop, and what we don't know is an ocean. Thank you for listening.